Hello, my name is Sebastian Sattui, and I'm a physician and a rheumatologist at the University of Pittsburgh in Pittsburgh, PA. My specific focus and interest, of course, vasculitis and PMR. It's a pleasure to be talking today about which patients or individuals with PMR need to be referred for rheumatology care and assessment. So, a very unique thing about PMR, polymyalgia rheumatica, compared to a lot of our other conditions, is that PMR tends to be very commonly, very frequently, actually managed solely under the care of primary care physicians or general practitioners, as they called in the UK. And some of the data that most of the epidemiological data that we have actually comes from the UK, and some of their numbers have shown that up to 82% of patients with polymyalgia rheumatica are exclusively taken care of by general practitioners. The one source of epidemiological data that we have in the US that comes from the Olmsted County actually shows that up to 40% of patients, these are a little bit older data from like, I would say early 2000s, up to 40% of patients with a diagnosis of PMR actually did not see a rheumatologist during over 4 years of mean follow-up, while 28% of them saw a rheumatologist once. So this is certainly very unique, and this is certainly very different for patients compared to most of our other rheumatic conditions, and also taking into account that in individuals over the age of 50 and even more during kind of above the age of 60, PMR is one of the most frequent systemic inflammatory conditions. uh, and what, besides this kind of unique aspect, PMR by itself has some other specific, I guess, challenges or aspects that are unique to itself. One is that there's no specific diagnostic test for PMR. We don't have any serologies to depend on. We don't have any kind of a specific imaging, as much as certainly there is an uptake in the research with regards to imaging studies to diagnose or assess for PMR. And the second thing is that we're talking about a lot of older adults that certainly are going to be quite potentially vulnerable or at higher risk, given the higher kind of prevalence of comorbidities, to the use of glucocorticoids and the prolonged use of it. So, in my very sincere and honest opinion, which could be, again, there are challenges to this, and certainly that I think the one also limitation in the study and the care of polymyalgia rheumatica is there's significant gaps in the care of these patients. But the first thing is, my opinion, I think most patients with either a suspected diagnosis of PMR or with PMR should be assessed by a rheumatologist. And again, this goes in line with some of the points that I've brought up. First of all, as much as I think we all retain the classical description and of patients with PMR or suspected PMR, it is a challenging diagnosis. We know that it is. We know that there's data that actually showed that up to 30% of patients who initially received the diagnosis of PMR by a rheumatologist actually had a different condition. In a recent global survey that included both general practitioners and rheumatologists, when patients were seen by a rheumatologist after a referral from a PCP, there was a kind of on average 15% of patients ended up having a different diagnosis, and this kind of range from 5 to up to 30% again. So we know that there are challenges in the diagnosis of PMR. Not everyone has a classical presentation. Not everyone is necessarily, and again, we have our tools are a little bit more limited compared to other conditions. A second reason for this is that we know that GCA can actually be occult or be quote unquote subclinical in some patients with PMR. And certainly we are more in tune of the diagnosis of giant arteritis as well as we are for the diagnosis of PMR compared to non-rheumatology colleagues. So the assessment also is certainly critical. And the third thing is that we know from some kind of published limited experience that the early referral and early assessment of patients with PMR, particularly prior to the starting glucocorticoid treatment, can be beneficial. There's a couple of studies that show that fast track referrals can actually lead to an earlier, more correct diagnosis, more rapid diagnosis, and actually the use of lower doses of glucocorticoids as well. And there are benefits as well of the shared care between primary care physicians and and rheumatologists, and this has been shown in a couple of studies that, although again with some limitations, show that one, lower doses of glucocorticoids were used, which certainly translates into a decreased risk of glucocorticoid toxicity, and second, the use of addressing and the use of medications to prevent glucocorticoid-induced osteoporosis or the management of osteoporosis in these patients. So in summary, I think everybody with a suspected or a diagnosis of PMR should be seen. Now, there are certainly limitations, and there's issues, of course, in the workforce and limited, and in some places in particular, limited access to rheumatology care or assessment. So, as a starting from the starting point of everybody, I think there are patients that certainly need to be prioritized, and that patients who are at higher risk, and you can actually split this group of individuals into two different purposes. One are diagnosis. Patients, for example, who are younger, below the age of 60, so younger patients with PMR should be assessed as well, given that it's it's not necessarily a typical population that you would suspect this. Patients with a typical presentation, lack of shoulder pain, lack of morning stiffness, lack of elevated, like normal inflammatory markers or pretty significant elevated inflammatory markers, those are patients that also should be prioritized as well. Pretty severe systemic features, significant weight loss, high fevers, those patients also need to be, again, from a diagnostic standpoint, anyone who is, of course, suspected to have any symptoms that raise a concern for GCA, they need to be immediately seen by rheumatologists, or patients who have any other features concerning for any other systemic rheumatic disease. From a therapeutic standpoint, patients that should also be prioritized are patients who, when started on prednisone, they have an either incomplete, partial, or lack of response to 15 to 20 milligrams of prednisone. Those patients, of course, need to be assessed by a specialist to either reassess for the diagnosis, also in particular suspicion for GCA. Other patients that also need to be kind of assessed from a therapeutic standpoint, and again prioritize, are patients who are having frequent relapses early on while trying to taper glucocorticoids, especially nowadays that we're having more evidence about glucocorticoid sparing agents for the treatment of PMR. Patients who are at a high risk of glucocorticoid toxicity, patients who already have osteoporosis, patients who have a diagnosis of diabetes, patients, obese patients as well, where the prolonged use of glucocorticoids are going to certainly bring or exacerbate already existing problems. And historically, another population that has been, and this is, for example, guiding from some of the UK guidelines, is patients who have been on prolonged use of glucocorticoids. I think the time is actually mentioned to be 2 years, which I say it's probably too much, because at that point the assessment is certainly going to be challenging. So I would say kind of frequent relapses or difficulty tapering early in the first few months is something that should raise concern. But again, these are lists that I would say are based on some evidence and based on more expert opinion, are patients who need to be prioritized. But I go back to my first pitch to everybody, that all PMR patients should be seen by a rheumatologist. Whether that timing of referral should defer or stop or hold, put the starting glucocorticoids on hold, that is probably something that needs to be discussed with the patient, and should be a decision should be made as a result of shared decision making. I think it's, in the ideal setting, patients should be seen off glucocorticoids, given that we know the rapid response, changes on even imaging, on inflammatory markers. But again, everybody ideally without glucocorticoids, depending on what the discussion with the patient is. And I think we need to have a more active role in the care of these patients. So that was my conversation regarding which patients need to be referred to rheumatology. Please let me know if you have any thoughts or any questions. Feel free to comment. And again, thank you again.